there is elevated pulmonary vascular resistance or the PVR, causes hypoxemia due to the decreased pulmonary blood flow and also due to the right to left shunting of the blood. What are the predisposing factors to develop pulmonary hypertension in the newborn? It can be due to birth asphyxia or secondary to a lung parenchymal disease where there is a poor oxygen entry into the alveolar space, such as meconium aspiration syndrome, with or without asphyxia, respiratory distress syndrome or the RDS, or pneumonia, which is the case in our patient, or sepsis, where there is maladaptation of the pulmonary vasculature, remodeled pulmonary vasculature with normal lung parenchyma, or there is a lung hypoplasia, which is due to a underdevelopment. It could be due to oligohydramnios, congenital diaphragmatic hernia, or an intrinsic obstruction like your polycythemia with hyperviscosity. And also, serotonin increases fetal PVR, and the use of SSRI during the last half of pregnancy has been associated with an increased incidence of PPHN. And also the arachidonic acid prostacyclin pathway, which play a role. The prostaglandins activate the adenate cyclase to increase the T-amps concentration in the vascular smooth muscle cells. So inhibition of this prostacyclin production by NSAIDs, especially during late pregnancy, has been associated also with PPHN. So disruption of the normal neonatal circulatory transition due to any of these factors can result to failure of the fetal circulation to resolve, hence the persistence of the pulmonary hypertension in the newborn. So let's tackle a bit about the fetal versus the neonatal circulation. So the fetal circulation differs from that of adult circulation in many ways to support the unique physiologic needs of a developing fetus. So in the fetal circulation, the lungs do not provide the gas exchange, and in fact, the pulmonary vessels are vasoconstricted, so it diverts the blood away from the pulmonary circulation. So what happens is that the placenta provides for the gas and the metabolite exchange. And we know that there are 3 cardiovascular structures that are unique to the fetus. So these are your ductus venosus, foramen ovale, and your ductus arteriosus, which are important in maintaining the parallel fetal circulation. So the left picture here shows the percentages of combined ventricular output that return to the fetal heart and that are ejected by each ventricle and that flow through the main vascular channels. So this picture depicts the fetal circulation. The red indicates more highly oxygenated blood, and arrows indicate the direction of the flow. So again, the placenta is not as efficient as an oxygen exchange organ as the lungs, so that the umbilical venous PO2, which is the highest level of oxygen provided to the fetus, is only about 30 to 35 millimeters mercury, and approximately 50% of this umbilical venous blood enters the hepatic circulation, whereas the rest bypasses the liver and joins the inferior vena cava via the ductus venosus, where it partially mixes with the poorly oxygenated inferior vena cava blood, which is derived from the lower part of the fetal body. So this, combined with the lower body plus umbilical venous blood flow, enters the right atrium and is preferentially directed across the foramen ovale to the left atrium. So this is the major source of the left ventricular blood flow, as pulmonary venous return is minimal. So the left ventricular blood is then ejected into the ascending aorta, where it supplies predominantly the fetal upper body and also the brain. The fetal superior vena cava blood, which is considerably less oxygenated, will enter the right atrium and preferentially will flow across the tricuspid valve, rather than the foramen ovale, and then into the right ventricle. So from the right ventricle, the blood is then ejected into the pulmonary artery. Because the pulmonary arterial circulation, as what I have said a while ago, is vasoconstricted, so only a small portion of this blood, which is only approximately 5% of the right ventricular outflow, will enter the lungs. So the major portion of this blood bypasses the lungs and flows right to left through the ductus arteriosus into the descending aorta to perfuse now the lower part of the fetal body, including providing flow to the placenta via the two umbilical arteries. So, thus in the fetal circulation, so only a small volume of blood from the ascending aorta, which is only about 10% of the fetal cardiac output, will flow all the way around the aortic arch to the descending aorta. And the total fetal cardiac output, which is the combined output of both the left and right ventricles, is only approximately 450 ml per kilogram per minute. And approximately 65% of the descending aortic blood flow returns to the placenta, and the remaining 35% perfuses the fetal organs and tissues. So now what happens? The one that I discussed a while ago was the fetal circulation. So now what happens at birth? So as the baby takes its first breath, there is a mechanical expansion of the lungs and an increase in arterial PO2 that results in a rapid decrease in pulmonary vascular resistance as a consequence of the vasodilation secondary to lung inflation. Also, after removal of the low resistance placental circulation, so after cutting the umbilical cord, this leads to an increase in systemic vascular resistance. And removal of the placenta also results to the closure of the ductus venosus. And the once vasoconstricted pulmonary vascular, the output from the RV now will flow entirely into the pulmonary circulation. So the high arterial PO2 constricts and eventually closes the ductus arteriosus, and its remnant becomes the ligamentum arteriosum. Since the pulmonary circulation is already functional, there is already increased pulmonary blood flow returning to the left atrium, which increased the left atrial volume and pressure, resulting to the closure of the flap of the foramen ovale functionally. So the left ventricle, which in the fetus pump blood only to the upper part of the body and brain, must now deliver the entire systemic cardiac output, which is approximately 350 ml per kilogram per minute, an almost 200% increase. So this is how the normal transitional circulation in the neonate occurs. So, but what happens if there is persistent pulmonary hypertension? There is persistently increased pulmonary vascular resistance. So after birth, the PVR again should normally decline rapidly as a consequence of the vasodilation secondary to the lung inflation, and also secondary to the rise in the postnatal partial pressure of oxygen, reduction in partial pressure of CO2, increased pH, and release of vasoactive substances. However, this does not happen in persistent pulmonary hypertension in the newborns. So this is a result of persistently high PVR relative to the fetal systemic or postnatal pulmonary pressure. So an increase in neonatal PVR may be the result of increased pulmonary artery medial muscle thickness and extension of these smooth muscle layers into the usually non-muscular, more peripheral pulmonary arterioles. Usually this is in response to chronic fetal hypoxia. And also it could also be a consequence of pulmonary hypoplasia, like those patients with the congenital diaphragmatic hernia and also Potter syndrome. So for the clinical manifestations, it may be related to polycythemia, hypoglycemia, hypothermia or asphyxia, and also may result in severe cyanosis with tachypnea. So, those associated also with meconium aspiration, GBS pneumonia, diaphragmatic hernia, or pulmonary hypoplasia, they may present with cyanosis, grunting, flaring, retractions, tachycardia, and even shock. And myocardial ischemia, papillary muscle dysfunction with mitral and tricuspid regurgitation, and biventricular dysfunction can also produce cardiogenic shock with decrease in pulmonary blood flow, tissue perfusion, and oxygen delivery. So in these patients, usually severe cases, we have labile hypoxemia. So it is when there is marked change in oxygen saturation with minimal or even with no changes in ventilation settings or in the fraction of inspired oxygen. So these cases are the severe ones. For the severity of pulmonary hypertension, it could be assessed by the oxygenation index or the OI, and also the alveolar arterial oxygen difference or the AADO2. So OI is calculated as OI is more commonly used during medical management of PPHN, since it also takes account the ventilator support. So OI, where MAP is the mean airway pressure in centimeter water, and FiO2 is the fraction of inspired oxygen. PaO2 is the partial pressure of oxygen in the arterial blood. But more recently, the oxygen saturation index or the OSI has been used in patients without arterial access. So for mild cases of pulmonary hypertension with minimal or no respiratory distress, it can be detected in the newborn nursery either following a desaturation episode, which is the case in our patient, or by low postdactal oxygen saturation detected on critical congenital heart disease screening. So in our setting, we are slowly incorporating the critical congenital heart disease screening for patients presenting with respiratory distress, especially those with cyanosis and desaturation. So these infants can be managed with supportive care and oxygen supplementation. For the diagnosis, again, measurement of the preductal and postductal oxygen saturation. So more than 5 to 10% difference, and the PaO2 differences of 10 to 20 millimeters mercury are considered significant. We can also request for complete blood count and also to the echo with Doppler flow imaging, which is still the first choice. For the echo, there is a peak velocity of the tricuspid valve regurgitation jet. So when present, it yields a quantitative estimate of the right ventricular systolic pressure. So the direction and velocity of a shunt across the PDA provides a quantitative comparison between the aortic and the pulmonary artery pressure. We can also request for chest X-ray, which is often helpful to diagnose underlying causes, and also in patients, especially in patients with ventilatory support, to assess the response of the patient. So again, pulmonary hypertension associated with pneumonia and diaphragmatic hernia, also those with parenchymal opacification and bowel or liver in the chest, which can be seen on chest X-ray. So in our patient, aside from the echo result of PDA, upon chest X-ray, there is also findings of pneumonia. So as what I have said, echocardiography is still the first choice for non-invasive quantitative estimates of newborn's pulmonary artery. So what are the possible findings in echocardiography? There could be right ventricular hypertrophy, deviation of the interventricular septum, tricuspid regurgitation, which is present in our patient with peak systolic pressure gradient of 32 millimeters mercury. There could also be a right to left or a bidirectional shunting at the patent foramen ovale and patent ductus arteriosus. So these are the cardinal echocardiographic findings in patients with persistent pulmonary hypertension. For the treatment, initial management still oxygen administration, and to address the underlying cause like correct the acidosis, hypotension, and hypercapnia. And if needed, intubation and mechanical ventilation may be done for persistent hypoxemic patients. But currently, the infants with PPHN are managed with gentle ventilation, that is with normocarbia or permissive hypercarbia, and avoidance of hypoxemia. For severe cases, they may need inotropic therapy, and dopamine is still the first-line agent. But for patients with poor myocardial contractility, we can start with dobutamine or epinephrine or milrinone. But I believe milrinone is not present in our setting. So in our nursery, we usually use either dopamine or dobutamine. And hydrocortisone as well, which is a hormone substitute in cases of patients with adrenal insufficiency. Again, for severe cases, nitric oxide can be used, which is endothelin-derived signaling molecule that relaxes the vascular smooth muscle. So, another is prostacyclin, which can be given continuous inhaled or intravenous. And also, we have the sildenafil, which is a type 5 phosphodiesterase inhibitor. The sildenafil, which acts through inhibiting the type 5 phosphodiesterase, results in increased level of CGMP. It is the same with, the action is somehow the same with nitric oxide, which stimulates the production of SGC or the soluble guanylate cyclase, and this results to the production of CGMP. An increase in CGMP as well as in PAMP in the pulmonary arterial smooth muscle cells reduce the systolic ionic calcium concentration. And so this induces the smooth muscle cell relaxation and also pulmonary vasodilation. Extracorporeal membrane oxygenation, or the ECMO, which is a form of cardiopulmonary bypass, augments the systemic perfusion and provides gas exchange. So it can be veno-arterial bypass or a veno-venous bypass. So most experience has been with the veno-arterial bypass. This requires the carotid artery ligation and the placement of large catheters in the right internal jugular vein and carotid artery. So this is the setup for extracorporeal membrane oxygenation, which requires complete heparinization to prevent clotting in the circuit during the procedure. So for the prognosis, long-term prognosis for infants with PPHN who survive after treatment with hyperventilation is comparable to that for infants who have underlying illnesses of equivalent severity, like those patients with breath asphyxia, polycythemia, or hypoglycemia. And the outcome for infants with PPHN treated with ECMO is also favorable, with more than 80 to 90% survival rate, and 60 to 75% of survivors appear normal at 1 to 3.5 years of age. So survival of infants born with congenital diaphragmatic hernia has increased over the past 10 years as well.